Okay, I'd like to thank Dr. Lim and Dr. Chan for two really excellent and very thought-provoking lectures. They're here with us now in our Q&A session to go over any of the questions you have. And I will jump right in with some of the questions that have already come through. Ramona, so the first question here is, so if someone has a false positive fit, do you recommend stopping FITs as a future screening option rather than doing screening colonoscopies?
Great question. I think it all depends. Depends on circumstances of why the fit may have been a false positive, whether it was hemorrhoidal bleeding, other issues. Certainly, if it's being used as opposed to the older technology FOBT, then we're going to reduce the risk of having false positives from diet. I think it depends on patient preference, right? So, you've already had an individual probably undergo colonoscopy then to confirm, and depending on their preference, certainly could opt to offer colonoscopies every 10 years if it was negative. But if the patient really strongly prefers the option of a stool-based test, then I think that a FIT is not necessarily completely out of the question for the future. It just means it'll be repeated if it's positive.
Right, but just to be clear, that patient would not need a FIT for 10 years if they had a colonoscopy.
Correct.
Right? So you would.
So they could repeat it in 10 years.
Okay. All right. Great. And so, Dr. Chan, so here's the first question here is, to what degree are the lifestyle and dietary factors that play in colorectal cancer, what's their contribution versus genetics? And I guess, does changing the diet really do anything?
So I think what I was hopefully able to kind of show you from modeling studies is that there is a substantial proportion of colorectal cancer risk that is lifestyle driven. I think the best quantitative estimates we have would be maybe up to 60% of someone's risk is based on some things that they can do that are modifiable in their lifestyle. So that would include diet, body weight, physical activity, alcohol intake, smoking. And if you also look at some of the studies where they've tried to combine genetics with lifestyle, lifestyle is actually in aggregate a stronger predictor of who's going to develop cancer than sort of common genetic variants. So this is, excluding hereditary syndrome. So if you're thinking only about common genetic variants, the additional contribution of common variants to risk on top of lifestyle is actually not as great as you would think. So I think there's a lot to be said about lifestyle. And I think among, cancers overall, colorectal cancer is considered one of the most likely to be lifestyle driven, and the one that might be the most likely to be responsive to dietary changes.
So just to follow up on that, Andy, is in your work, or are you able to create a score, so to speak, you can, for this much smoking, this much weight, being overweight, this much alcohol, in order to use it in a practical way, when we try to risk stratify our patients. I imagine ultimately down the road, we would like to be able to say, oh, you are in this high, medium, or low risk category. And is there a kind of a scoring system that you have in place or that are developing that could ultimately be easily used clinically?
Yeah, so there have been several different risk prediction scores that have been developed. Prediction scores that have been developed from my group, which are some of the slides I presented earlier, but also from other groups, where it allows us to provide a quantitative measure of risk. And with that quantitative measure, you could use that to help estimate someone's relative risk of colorectal cancer. And use that as a way to potentially tailor interventions. And so I showed some examples of that. For example, if you compare people kind of in the highest 20% of risk, you potentially could use that data to actually shift the age at which you would potentially start screening compared to people that are in the sort of average risk or low risk. You could also use lifestyle scores to potentially also help you to define surveillance intervals. So after someone has a polyp, you may be able to use a lifestyle score to kind of lifestyle score to let you know like what might be the more optimal screening interval above and beyond just using adenoma pathology and those kinds of characteristics. Those scores, I think, are being developed by a variety of groups. I think they've been recently meta-analyzed into sort of more simple scores. So I think there's an enormous potential for those in the future.
While we're just on the topic, I'll just follow up with another question for you, Andy. Just the question here is about, so does counseling someone to make these lifestyle changes at age 50 make a difference? Or is it really that you really need to have been doing this since you were, 15 years old?
Well, that's we can only do what we can. So if the patient in front of you is age 50 and you haven't seen them before, I guess you can only advise them about what to do now. But clearly we know that there's probably a role of early life style factors in terms of risk. So and as we all know, there is this growing problem of early onset colorectal cancer. So it's pretty clear that these lifestyle factors do also have a really important role in earlier stages of life. So we do probably need to think about shifting lifestyle counseling to even younger ages. I think the real, difficult problem though is that we're not seeing a lot of people at younger ages, routinely in medical care. So, we can only do what we can. But I think in terms of public health messaging and in terms of thinking about the overall population, I think we increasingly have to think about, dietary guidance, guidance about overweight, obesity, alcohol, and sending those sort of public health messages to younger populations with the idea that, they potentially might play a role in sort of population level decreases in incidence.
Great, thank you so much. So there's a question here about high-risk pancreatic cancer surveillance, so I'll just address that one now. So, the question relates to getting a lot of pushback from insurance companies about ordering imaging for surveillance with no symptoms and tips for trying to get coverage for that. So I will say that sometimes can be challenging. For the vast majority of the cases, though, we have not really had a problem getting coverage, and these are the few things that have been generally helpful and successful. So, number one, we do have a code for hereditary genetic syndrome, which generally does seem to get covered. Number one. Number two, there are a number of individuals who have started screening and will, end up invariably having like an IPMN or something. And once you have a finding like that, this follow-up surveillance will almost always just be covered because of the fact that there are these IPMNs. And then the third thing, though, is whenever there is a question, and for MRIs, I think a lot of places will require pre-approval processes first. I have not infrequently had to do a peer-to-peer review with someone to get the coverage. I will say, 99 times out of 100, they will agree to the coverage when I do that. And the way to justify it is through, citing various national guidelines that do recommend that these tests actually do happen. And you can certainly quote from the NCCN guidelines, which would recommend a high-risk screening for those individuals. So it is extra work. I recognize that is, something that a lot of us don't have really that kind of time, but I can at least assure you that when you do it, you will be successful to get that covered. Dr. Lim, so there's a question here about if a patient has an advanced adenoma at an age younger than 40, let's say they're 35, do you recommend that siblings start CRC screening 10 years or 5 years younger prior to the age of diagnosis?
So I think in those scenarios, an advanced adenoma would actually be treated similar to if an individual had been diagnosed with a colorectal cancer. And so their first degree relative, their younger sibling, would be advised to start 10 years younger than that diagnosis. it sounds like a really young age to start, but certainly we are identifying individuals with younger onset colorectal cancer, which is still to be determined in terms of exploration as far as etiology.
Great, terrific. I agree. And the only thing I would add there is that so if you do have someone who has an advanced adenoma at age 35, that certainly is someone who you should refer for genetic testing, as that whether that may represent indeed a hereditary syndrome in that case.
And discuss lifestyle modification.
Absolutely, all prongs. Dr. Lim, patients, I'm assuming this is for someone with chronic UC. So patients who've demonstrated endoscopic remission, should you still do surveillance with colonoscopy every 1 to 2 years?
So good question. I mean, I think that the degree of inflammation certainly is something that is felt to contribute to their risk of colorectal cancer. Unfortunately, endoscopic remission and clinical remission may not be things that would protect that individual who's had longstanding colitis from having an increased risk of colorectal neoplasia. Certainly, I think the folks we had called out in the discussion had been individuals, for example, who may have had a high risk like PSC diagnosis, individuals who may have had prior dysplasia or stricture, and certainly those individuals with strong risk of colorectal cancer based on the family history. But certainly I think individuals who are lower risk may be okay for a 2 to 3 year interval.
Okay, great. Thank you, Ramona. So there was another genetic question about genetic testing. So if you have someone who has a family history of colon cancer, do you mean even an age greater than 60? So the answer for that is yes. So this is the scenario where you're talking about an individual, a patient of yours who has colon cancer, and there's also a family history of colon cancer as someone being you would consider for genetic testing. And so if that relative even has colon cancer greater than 60, yes, you would consider that. Andy, Dr. Chan, can you, okay, I think you were kind of alluding to this, but can you comment what we know about lifestyle or environmental factors that are responsible for this rise in early onset colorectal cancers?
Sure. So from what we know so far, the established risk factors for colorectal cancer I discussed, which apply to older individuals, specifically diet, overweight, obesity, alcohol, physical inactivity, smoking, those have been studied as potential contributors to the rise in early onset colorectal cancer, and they do seem to be playing a role, but they're not the complete story. I think we all have examples of patients that have none of those risk factors that come into our clinics with, advanced adenoma or cancer. So it's not the complete story, but they do seem to be contributing to risk. So there is this, obvious need to understand what else could be out there that's driving this increase. And that's one of the things that I think is really puzzling the scientific community, and which is really driving a lot of research into this area. There've been some provocative, hypotheses out there, which, need to be studied more in depth. For example, environmental pollutants, forever chemicals, microplastics. Those are all things that people have been hypothesizing is potentially driving the risk because they seem to be correlated with sort of this birth cohort effect we're seeing with early onset cancer, and also seem to be correlated with other chronic health conditions. So I think hopefully some inroads will be made into this question in the next 5 to 10 years.
Great. So Ramona, well, this question I think we answered already about normal colonoscopy. When do you recommend starting FIT? We would say 10 years after that normal colonoscopy if there aren't other risk factors. I guess this is a practical issue. Do you have any suggestions about what diagnosis code you could use for family history of advanced adenoma?
Unfortunately, no. I'm not aware of any diagnostic code specific to advanced adenomas. For family history, I think it would still be the family history of colon polyps.
Yeah. Okay. And then there's a question here about hereditary polyposis with innumerable recurrent polyps throughout the post-surgical, not able to remove, but a limited number at a time. So I'm not, so I'm surmising this is someone with like a familial polyposis who's had a total colectomy already, and either has lots of polyps either in the rectal pouch and or the rectal cuff. And I'm also surmising maybe there's lots of polyps in the stomach and upper tract as well. So so as far as the pouch and lower that goes, is that, as you know, anyone who's had a total colectomy for FAPs does require surveillance for the cuff as well as the pouch. Pouch polyps are not uncommon. Pouch cancer is actually quite uncommon, but it is important to monitor and remove polyps that you can, certainly those centimeter and larger. Now, if the number is so high and a lot of them show advanced adenomatous changes or even dysplasia, you do have the options are actually quite tough. And so it either ends up being another resection with an end ileostomy, or you can try to do aggressively remove as many as you can endoscopically and consider other strategies such as chemoprevention with adding either things like sulindac or celecoxib to your regimen as well to see if you can reduce the number of adenomas that are present. But in cases like these, we would recommend that individuals like this are referred to an academic center that has probably expertise with familial polyposis patients, and that would be particularly true if they were gastric and duodenal, because those are actually quite challenging to manage if indeed the number is not is particularly high and there is a lot of dysplasia. I will just maybe end with this last one here, Ramona here. Given the increased incidence of CRC in younger age groups, should we be doing colonoscopy in any young person with rectal bleeding?
Fair question. I think there is not an age cutoff anymore about when we recommend individuals for diagnostic colonoscopy with rectal bleeding. It's not part of guidelines anymore. I think it's with the caveat of clinical judgment, individuals may have rectal bleeding for obvious reasons such as constipation and straining, which resolve completely. So there is, however, the reassurance of a colonoscopy to ensure that there are not significant findings such as a colonic neoplasm. So I think there's no age cutoff. I think it'd be appropriate.
Yeah, unfortunately, yes, the threshold has become much lower. All right, so listen, I want to thank Dr. Chan, Dr. Lim for a fantastic session. And so this concludes the course for today. Thank you all for joining us. We will resume again tomorrow. We start again at 8:30. Yes, 8:30 again Eastern time. And tomorrow we'll be focusing on upper GI diseases as well as motility and neurogastroenterology. So thank you all again, and we'll see you tomorrow.